Asna, can you also just reach out to Shona, madam?
नीता मैडम,
Yeah.
आसना ने सोना मैडम से बात की, लेकिन वो बोले उनको थोड़ा टाइम लगेगा.
Okay. So then we'll start while we're waiting.
Okay.
Okay. Hi, good evening, everyone. Thank you for joining in. So the idea behind this was basically because very often most of us in clinics see a lot of cases where it's very different from what we see from published literature. We're looking to move things more into a practical domain. There's a lot of discussion on what we can interpret and bring into the clinic. One of the questions that started out was a lot of discussions that come up on the WhatsApp groups that we keep talking about. So we just thought we'll bring it to a platform where we can all sit and discuss cases, discuss concerns. We're going to try and do this every alternate month between us, and we're going to reach out to each of you to lead sessions out of these. We decided to start with B3 lesions, just trying to say, go back to the basics. And I think sometimes these are the tougher ones for us to actually interpret and discuss things, since we have more guidelines in place for what are malignant lesions. Both Shalaka and Manjula have been very kind and shared some of their cases. And we've got a very interesting group of people put together as a panel, most of whom have just been emotionally blackmailed into joining us for this. So I'm just going to jump straight to the presentation. Please let me know if you can see my slides.
Hi, everyone.
Yes,
Yeah,
we can see.
very clear.
Okay. So I'm not sure if I'm able to share the slides, and once, oops.
We can see your slides.
Okay, I for some reason can't see them, so sorry, one sec.
Oh,
Okay. Just give me exactly 1 second. I'm trying to figure out how to be able to see my own slides. I think I'm
yeah,
going to
that
just
will help.
share. Yeah, I'm going to just stop share and do it again. Sorry. Okay. Can you see the slides?
Yes.
Okay, perfect. So we've got a very esteemed group of panelists. I think Tanuja madam, unfortunately, isn't able to join us. I didn't realize she was traveling today, and there was a mix-up in the dates. But we've got Dr. Vani, Dr. Palak, Dr. Sanjay, Dr. Nadkarni is also in flight, Dr. Shalaka, Dr. Trupti, and Dr. Dipali. The idea, like I said, is just something Shona and I brainstormed on. Very grateful for all the support that she's given me in this madness, is to try and put together ideas that are concerning and dilemmas for us in the clinic. The first of these sessions is on B3. And the reason we've kept this open in terms of an open Zoom link is we want it to be interactive, but I'm going to request participants that if you have a concern, please raise your hand. We'll reach out to you. Don't want people talking simultaneously, but we do want everyone to talk through the topics and make this a very interactive discussion. So just for a couple of the students in the current group, we do know and we understand the concept of B3 lesions basically comes from the concept of what is BIRADS 3. And it will often enough just be lesions that are of different risks associated with malignancy. The common pathologies that we do understand from this type of terminology would be ADH, lobular neoplasias, including in situ carcinomas, flat epithelial atypias, radial scars, sclerosing lesions, and of course, papillary lesions. For us, however, the concern is most of this tends to be a histological diagnosis, and you're going to see malignancy associated in this group in less than 5%. Because these are obligate precursors of malignancy, often enough DCIS, we often tend to overdiagnose and overtreat them. So we need to understand where we actually need to draw the line, which group of people we are happy to draw the line in terms of keep them on close follow-up, and of course, what is close follow-up. Something that I found interesting, which even I didn't know, and when I was reading up for this, was 35% of these B3 lesions can be upgraded to DCIS or low-grade carcinomas. So I'm going to open this out to the clinicians in this before we move to the cases. And I'm going to talk to three different people. So there's someone in private practice, someone in an institutional practice, and someone who's working in a practice in a small town. So that's Dr. Vani, Shalaka, and Sanjay. Is when you get a patient who comes with a B3 lesion, and let's say your patient's had a core done outside, it says probably ADH or LCIS. What is the first choice that you would offer to this patient in terms of between a VAB, a VAE, or an excision? Dr. Vani, if you want to start.
Hi, and this is a very good topic you've picked up. So congratulate both you and Shona for having spearheaded this. So as far as the B3 lesions are concerned, it's not a common one kind of lesion. The B3 has to be correlated also with the clinical scenario as well. Now, B3 would be, I guess, a biopsy done for something something that was suspicious, biopsied outside, and has now come with any of these diagnoses that you have mentioned. The first and foremost that I would look at is I'm going to get it reviewed by another pathologist, because quite a few times you find that the opinion of one pathologist may differ from another, because there is a kind of I would say it's a plethora of lesions, and within them there can be a mix-up. So many a times they're called DCIS and they turn out to be ADH, so or atypical ductal hyperplasias. Similarly, ADH, what has been diagnosed, could be actually a frank low-grade DCIS. Now, so you have to have a good pathologist reviewing the situation on the biopsy, and invariably there would be a core natal biopsy that would have been done outside. So I think that's the first step. As far as the lesion is concerned, depending upon the size of lesion, site of lesion, and the degree of suspicion that the now review pathologist tells me, I would then base my plan on an excision versus a VAB versus a VAE. So there is no one answer to this question as to what would you prefer, one over the other.
So I'm going to ask you, would it matter if it's screen detected versus palpable?
Very much, because if it's a screen detected lesion, obviously I need another imaging to even find it. And if somebody has biopsied it, I'm sure they would have, if they have put a clip in, I am lucky. If they have already messed up the lesion because of the biopsy, I'm going to be struggling trying to find that lesion. So that would be my main concern when it comes to this. And if it's a palpable lesion, obviously it's so much more easier to then consider a guided biopsy or an excision, again based on the size of the lesion and the degree of suspicion. So I'm still being round and round, but you have to.
No, that's what I think. That's what the practical concern
clinical
is.
Management.
Yes, it's never a single answer for any of us. And I think a good take home, which I think I'm going to get Palak to weigh in on after Shalaka gives her bit, is that we'd hope that every time there's a screen detected lesion and a biopsy is being asked for, we are asking our radiologist to please place a clip in that, because once you do some sort of biopsy for a screen detected lesion and you don't have a clip to then follow it, it becomes very difficult both for yourself as well as any other surgeon that patient's going to go to next. So Shalaka, do you have a difference in how you'd approach this?
So I agree with ma'am in the sense that we need to know what is the other symptomatology. If there is any other palpable lump that, this is a second lesion in the same breast, then I would want to sample it more extensively to understand if it's a multicentric disease process versus one. But often enough, it may be a screen detected lesion and that's the only one that you have. And the biopsy says so. I think we need to do a complete excision in majority of these lesions, because the transition between ADH, the upgradation between ADH to a low grade DCIS could be seen only after you have completely excised it. So often after a VAB, initial VAB or initial ultrasound guided biopsy, which they would often be impalpable, I'm sure the radiologist wants you to excise it fully if there is any doubt of, having not adequately sampled it while doing the core biopsy or a vacuum assisted biopsy. But either stereotactic or ultrasound will depend mainly upon whether it is seen on mammography better or whether it is seen on ultrasound better. And that's how they would choose. Of course, she could talk about that. But we are looking at a complete excision to ensure that, there is no associated any other malignancy. VAB or VAE, initial would be a VAB or a UHG guided biopsy. But if you want to excise it fully, you could go ahead with an excision biopsy or a vacuum assisted excision. Both are fine. And vacuum assisted excision will have to be complete then. So the radiologist would need to spend more time and again put a clip, of course. But sometimes the cost of that could be high, even in our setting for our general patients. So rather, if it's just a sonolocalized lesion, doing an excision biopsy if the patient doesn't mind the scar is also a pretty valid option.
So Palak, I'm going to ask you here, is that if you see a lesion that's screen detected on imaging, okay, let's say you did an MRI because Shalaka sent some patient to you, on the opposite side, you find there's something that's a B3 kind of lesion. Would you be more inclined to offering this patient a VAE just because you think you'll get the whole lesion out and get better diagnosis?
Yeah, so first and foremost, I'm enjoying being here. It's so happy to connect with all of you. So I'm totally loving it, which is I can see that broad smile and me grinning. Now, if you allow me, can I like start talking and not just answer this one question?
So,
Sure. Okay, thank you. So the way I would look at it as, and covering the questions that have been put forth so far is the first thing is how was it detected, whether it was palpable or screen detected. So let me come at something which was screen detected. If it was a screen detected finding, then the question would be how large was it and which modality did we see it on? So for example, if I see a very small tight group of indeterminate or suspicious microcalcifications, and I've done a stereotactic vacuum assisted biopsy because that was the way to target it for diagnosis, and it comes up with a B3 pathology, but I'm quite certain that all of it has almost come out and I'm not seeing any other pathology, then I might take it to the MDT and discuss if we are okay to observe, because I have given a good amount of sample and I don't see a large thing left behind. So that is one way of looking at it. On the other hand, if it was screen detected, something had a correlation on ultrasound, and we did a core biopsy, and that core biopsy turns out to be showing us a B3 lesion, then I definitely know that I'm leaving behind something, whether it was palpable or impalpable. So that is when, again, we would have an MDT to discuss whether we would do a VAE or a surgical excision. I would not recommend VAB as a second step because we are leaving behind something. So if we are seeing something, then it needs to be a vacuum excision altogether and or a surgical excision. So both would be viable options. Coming to the second situation where it was palpable finding. If it is a palpable finding, then very often, if it is a palpable finding corresponding to a mass, again, it would lead to my ultrasound detected algorithm where I can either do, and it is a core needle biopsy diagnosis, we could consider a vacuum assisted excision or a surgical excision. However, sometimes we have palpable abnormality for non-mass findings, which would be a large area of non-mass findings on an ultrasound or an MRI. Now, these are honestly diagnostic challenges. And so even if I see a large non-mass area on an ultrasound, I think I would resort to an MRI before putting in a needle, because I always say it's like playing a blind dart game. I just don't want to stick in a needle anywhere. So we need to have an idea as to what it is, how does it behave on an MRI. Based on that, we then decide whether this needs to be biopsied or not. If there is a one tight area which is confidently suspicious, or at least I can triage that I think this is more worrisome than the rest, I could consider an MR-guided vacuum-assisted biopsy because it's a large area for excision. However, if I am not confident and the MR has not helped me, I think I would rather suggest a surgical excision for having the representation of the whole region out.
So I'm actually going to now jump to Sanjay, where there's not going to be any access to an MR-guided biopsy. Possibly, I think Sanjay has even done some slightly innovative work on doing VABs. Are you here, Sanjay?
Hi, yes, ma'am.
Tell me.
Yeah, very nice meeting you all. And actually, I am in Delhi traveling for a Department of Health research meeting. So you might hear some.
Don't worry, we're good with the traffic. Everyone's in it.
Yeah, so the answer to this question really is there are two things. One is your clinical finding, as Vani ma'am said, and second is how much do you trust your pathologist. So, so in setting like mine, so it is very difficult to find good pathology reports. And I especially tend to err on side of surgical excision. And but obviously, first, a good ultrasound guided biopsy is necessary. And recently, we had two experiences. One patient had Byrat's 3 lesion, and she underwent core needle biopsy twice elsewhere. And one time it was reported as fibrocystic disease, another time as atypical ductal hyperplasia. But when I saw her, the lump looked very much suspicious. So I said, no, I would like to biopsy it again. But patient already had 2 biopsies. She said, no, can you please excise it? I said no, because your management could change if it is malignant. So we did a core biopsy.
So, Sanjay, are you still there? Okay. So I suppose we'll go back to him when he comes back. Yeah.
Yeah. Another case we had, this
Sorry,
lady
we
had
missed the repeat biopsy. What did it come back as?
infiltrating duct carcinoma,
Yes.
IDC.
I think what's important with that is just that if clinico-radiologically there's a suspicion of something else, the pathology may not be as representative the first time round. So always repeat that. I think that's a good takeaway from that. Before you go to your next thing, I'm going to ask, is there any specific pathology out of the B3 lesions that would prompt anyone to push for an excision biopsy? So let's say if you have LCIS or you have ADH or you have flat atypia, go ahead, madam.
So I think the higher the risk and degree of suspicion with a particular lesion would be the one that I would push for an excision. For example, if I get an ADH which is, easily localized, in that situation, I would probably say even a surgical excision may be a better option because you will get it cleared and you will also have more tissue to differentiate between a DCIS and an ADH. And other than that, I'm not sure if there's anything else which I would really push for. Of course, a papillary lesion is another one where I would ask for an excision because I think a papilloma has to be completely assessed in a block and then you will understand the invasion. Otherwise, you might actually miss invasive things. So papillary lesions and ADH, in my opinion, would be the ones that I would push for an excision.
So I'm just going to jump to Trupti here if you're here. So
Yes.
on a core biopsy, a papillary lesion is going to come up more as a papillary neoplasm, so to speak. Are you going to be able to tell us whether it's a papilloma, DCIS on just a core biopsy?
So yes, so as we all know, the spectrum of papillary lesion is very varied. So when we look at any core biopsy with a papillary fragments, there are certain clues which will help us tell whether it is just a papilloma or you have some spectrum of like ADH, DCIS. We can try to characterize it. So for example, if you see a very delicate papillary fragments and there are no myoepithelial component, so most likely it is a spectrum of some encapsulated papillary carcinoma or some invasive papillary carcinoma. So this is the spectrum where we need excision. If I see broad papillary fragments and I see retained myoepithelial cells at the periphery and within the fibrovascular core, I am very much comfortable in calling it a intraductal papilloma. Now, sometimes some cores are showing proper papilloma, whereas some will show some sheets of monotonous looking epithelial proliferation. If in that, my two IHCs are very important, that is CK56 and ER. If in that monotonous looking population, if my ER is strong diffuse and my CK56 is absent, I will suspect some kind of papilloma with atypia. Then it definitely needs excision for proper characterization. So at least we'll try and characterize, but sometimes if it is not possible, we'll ask for excision.
Sounds fair. Geeta, I'm going to ask you why you would want to do this with sclerosing adenosis. Geeta?
So, see, sclerosing adenosis is also a risk. So if I were to get it on biopsy, I would want to take it out. And there is always this issue that kind of rankles in your head. So your B3 lesions depends on who's reading it. A B3 lesion may not actually be B3, maybe a B4. So, it is always better to err on the side of doing an excision. Sclerosing adenosis, I would excise.
Fair enough. So Vedant, with the phylloids, I'm going to actually leave that out here because with phylloids, we're going to do a completely separate take on it later because it's going to be a much bigger discussion. But anything that says a fibroepithelial neoplasia and does not tell us fibroadenoma versus phylloids, most of us would ask for an excision there. Neha, you've said something
Nita?
about... Yeah. Shalaka.
Nita, Shalaka here.
Ah.
So this was actually for Trupti. You know, Trupti, we have often discussed in our RADPATH meetings and MDTs also that a vacuum biopsy distorts the papilloma in a way that it appears more suspicious, isn't it? Because you say that the vacuum force kind of pushes the cell or something inside something. What do you talk about?
So you mean for VAB?
Yes.
So papillary lesions, I feel more comfortable on biopsies. At least in VAB, what happens, like you just see some papillary fragments here and there. Actually, we find it gets little distorted. And sometimes, after VAB, when you do excision, there are very high chances of some cases like the case we know about epithelial displacement, again causing some diagnostic hindrance.
So one of the things I remember Tanuja madam always saying is that if you've done a vacuum-assisted biopsy or an excision and then something in that comes back as a malignant component, she can't put together to tell us what the tumor
Yes,
size is.
exactly. Yeah,
That's
the
another
issue.
concern that gets raised with a lot of these papillary lesions.
So Nita,
But with vacuum assisted, I think, if you have a papilloma and the patient is symptomatic, she's got nipple discharge, and you get rid of that papilloma, it is actually not just diagnostic, but it is also therapeutic.
Completely agreed. I think I always tell patients that if you have nipple discharge, the biopsy is going to tell me what it is, but the microdocectomy is going to get rid of the discharge also. So could not agree with that more. Yeah. Yes, Dr.
I'm just going to add one more comment, and I think Palak as well as Trupti will definitely know this because I've said this many a times before. I don't really push for a VAB or a VAB for a patient where you're looking at a B3 lesion where you're anyway going to intervene on one side. On the other side, you do a VAB and you end up with a lesion which is malignant and you probably would lose out on the margins as well. So I would be much happier doing an excision in that situation. If it's a small lesion that you have to get a diagnosis, you're already operating on one side, you might as well do a localization. And why would you do a VAB? Because
that's assuming you have a patient who has a second lesion.
Correct.
But if this is her only lesion,
if it's the only lesion, then it's a decision that's to be taken again based upon her size of the lesion, degree of suspicion, and then you take that decision. So it's not bad for all. It is not bad for all.
So I'm going to tell you that, for me, it's a sudden shift to newer screen detected lesions, right? And you're suddenly seeing a lot of patients come in to the screening clinic, etc. A lot of them have these B3 lesions, which then look like papillomas on an ultrasound. They're asymptomatic. They do not have nipple discharge. So there you're then discussing, okay, I get a biopsy done, I get a USG guided biopsy done. If it comes back as a papilloma, am I supposed to just stop there? Versus am I supposed to say that, technically I should get it out or get a vacuum assisted excision on it? So,
but I also think that our radiologists are pretty astute in that manner, in the sense that they can clearly decide as to which ones would benefit from a VAB, so a lot of times, the description would make us a little wary because your papilloma description is an irregular lesion within the duct, which is kind of, the moment you read the word irregular, it kind of sends alarm bells.
I'm standing there with my tentacles up.
Yeah, so that's right. So,
like, why are you reacting?
But when you talk to the radiologist, they say, well, it looks like a papilloma, and most of the times, I think they'll end up being right. But if you see something on mammogram and there is a lesion, the likelihood of it being malignant is much higher than what you would just pick up on an ultrasound.
So I've not put that case because the girls gave me fantastic cases on their own. But I had a patient very recently, came with a vague palpable lump, honestly was screen detected, but I could feel the lesion. no nipple discharge, nothing. Ultrasound said looks like an intraductal lesion. Mammogram was not contributory. Beyond that, we got an MR done by someone absolutely excellent in the city. She was very clear they were all papillomas. We did a biopsy. It came back as an intraductal papilloma. But because there was something that just didn't fit between the patient and me, we had a discussion and I said, let's go ahead with an excision. The lady has high-grade DCIS with a 4 mm IDC. And both the radiologist and I are just staring at it. I actually sent slides to Tanuja madam who said, no, there is IDC. Why are you panicking? And I was like, no, I'm panicking because it was not something I expected. So the thing is that, even with some of the best radiology, sometimes I think that your clinical decisions have to sort of lead the discussion more than anything else. Palak, I'm not putting the radiologist down. I think you guys are excellent. You're always the person I end up crying to. But the point is, I still feel that
So
there's
we
something
all
missing.
err and we all are wrong at some point of time. So I would not defend in any point of conviction. But what I would just say is, like as Dr. Geeta was suggesting that, there's an irregular mass or something. So for me, I don't know if I'm right or wrong, but if I see a prominent duct with a small papillary frond, like irregular mass within, which is vascular, and I know for sure that these are not inspissated echogenic secretions. So in that case, I would upfront recommend a microdocectomy when it is closer to the nipple or areolar region. I wouldn't want to fidget with it. If it is a little larger in size and we want a preoperative diagnosis, I will suggest a core needle biopsy and I will not do a VAB. Secondly, coming to if we are expecting that maybe this is a nice, well-defined, homogeneous, small little soft tissue, like, some of these incidentally lesions which come up, which are 4 millimeter, 5 millimeter in size and clinically asymptomatic. So maybe a fibroepithelial lesion, maybe a papilloma, small little vascularity. Again, recommendation would be core biopsy because my institute and my pathologists teach me enough not to mess around with a papilloma. However, if we still want, it is only those kind of lesions where I'm very certain I might call her as a category 3 or category 4A. There, and if there are multiple, how much is the surgeon going to excise? Which is the worst looking? In that case, we might probably do a core needle biopsy or a vacuum excision of one of those worst looking lesions. But that is in the event where we see multiple lesions on both sides or one side. Otherwise, it would be a core needle biopsy and a surgical excision.
Sounds fair. So we're going to actually jump to a pathologist comfortable reporting. Vedant, I think Trupti answered this, suggesting that with papillary lesions, it's not as simple, but she needs to see certain specific pathology and she'd look at some immune markers. Immune histochemistry markers. We're going to jump to the case. Manjula, are you here or is your SR here? Hi, Divya, can you present and I'll keep moving slides.
Dr. Nita, can I just ask, answer one of your questions? You were asking about which lesions among B3. So I feel columnar cell alteration or maybe a flat epithelial atypia, pleomorphic LCIS or florid LCIS. These are also some lesions which will, these are high risk among B3s.
So you would want us to excise these and think that we should get the whole lesion out. I think that's a point very well taken. So Divya, if you'd like to present and you can just keep saying next slide and I'll go ahead for you.
Sure, ma'am. So I just want to inform that Dr. Manjula is traveling and she couldn't join us today, but our pathologist, Dr. Sushma, is with us in the audience.
Excellent.
So going ahead with the case presentation, we had a 32-year-old premenopausal lady with no family history of cancer who presented to us with a Birat's 3 lesion. Next slide, please, ma'am. So she came to us in July 2022 with the following history. So from December 2019, she had spontaneous, occasional straw-colored left-sided nipple discharge. She was evaluated at her hometown and an ultrasound reported a Birat's 3 ill-defined intraductal solid mass of 1.1 into 0.7 centimeters at 12 o'clock radian in the left breast with some microcalcifications. Next slide, please, ma'am. So the lesion was biopsied and it came as benign proliferative breast lesion, query intraductal papilloma, and she was advised observation by a surgeon and she was on regular follow-up. In 2021, a repeat ultrasound showed a dilated duct with a 0.3 centimeter solid isoechoic lesion at 7 o'clock radian in the left breast. And the distal aspect of the duct shows a 1.7 centimeter mildly lobulated irregular Birad's 4 lesion with the possibility of intraductal papilloma. And after this ultrasound as well, she was advised observation and regular follow-ups. Next slide, ma'am. So when she presented to us in July 2022, these were her clinical findings. There were no palpable abnormalities, nor was there any nipple discharge from bilateral breast. But there was a 0.5 centimeter node palpable in her right axilla. Next slide, ma'am. So we advised her an MR mammogram with second look ultrasound, and left mag views were also taken. So the breast parenchyma was heterogeneous with the moderate background parenchymal enhancement, and the magnification view showed us the intraductal papilloma at 11 o'clock radian. And adjacent to it, there was another lesion which was given query papilloma or query debris. And there was a linear enhancing lesion in the retroareolar region at 12 o'clock, which was Birad's 4A. So we biopsied this retroareolar 12 o'clock lesion. And next slide, ma'am. So the biopsy was benign breast tissue with stromal fibrosis and focal adenosis, but there was a single focus of detached papilloid fragment within. But there was no evidence of malignancy or atypia. Next slide, ma'am. So we took up her for microdocectomy, and we did ultrasound guided localization and excision of the intraductal papilloma. So perioral incision was taken from 10 to 1 o'clock, and both intraductal lesions along with the 11 o'clock dilated duct was removed. And we've used clips prior to ultrasound to localize it by ultrasound guidance, and the clips were removed along with the lesions. So the final histopathology was atypical ductal hyperplasia with intermediate grade DCIS occupying 10% of the lesion. All margins were free and there was no invasive component. Next slide, please, ma'am. So these were the pathology images. I think Dr. Sushma will be able to explain the images better. So these were the ducts that are seen with columnar cell changes.
I need to check in.
Manjula?
Sorry, I've just logged
I
in.
can see you, no worries.
Sorry, everyone.
Is Dr. Sushma here?
Yes, I am here. Can you hear
Dr.
me?
Sushma's online.
Yes,
She's
madam, go
online.
ahead.
Can you hear me?
Yes, madam, we can hear you. Go
Okay.
ahead.
Go back to the first slide, please, if you don't mind.
Yeah. There you go.
I just entered my house, okay? I was also traveling. So this is the first slide I took. I'm telling you because we got the microdotectomy specimen and we serially sectioned from anterior to posterior, from the nipple end towards the posterior aspect. And I have taken the first slide to show you what a normal terminal duct lobular unit looks like. I'm telling you a honest confession of a pathologist from 25 years of experience. Breast pathology is full of landmines, particularly with B3 lesions. Okay, I make that honest confession before I go anywhere further. And we are at the mercy of the clinician as well as the radiologist performing these biopsies. I have seen a 18 gauge, I have seen 16 gauge, I have seen 14 gauge, and I have seen 12 gauge biopsies. And with each gauge that I get, the diagnosis changes. So please bear with us. We are also humble creatures, bottom dwellers. We do our best to give the best to you all.
I love the modesty.
Yes, I'm telling you. I'm telling you.
They're probably the ones telling us what to do. Go ahead, madam.
Pathologists are gods.
I know.
No, believe me. I'm telling
We
you
are the
that
lesser mortals.
the weight is very heavy on our shoulders. Okay, so I'll not digress first. Okay, so this one I showed you to show what a benign terminal duct lobular unit looks like. If you look at the lower half, there is one linear duct, and the neck adjacent to that you're seeing is lot of lobules. This is the best I could do for a terminal duct lobular units, and each is lined by a basal layer and a luminal epithelial layer. So to understand abnormal, I should always first tell you what a normal looks like. So that is why I put this slide from the same patient, okay? And you can see one ectatic duct that was there. And I didn't take the papilloma, it was straightforward papilloma, and we did not have much issues diagnosing that, but it had caused dilatation posteriorly, wherever it was from there on. But what was more interesting was what was there besides the papilloma that this microdotectomy had captured. Next slide, please. At low power, you can see several ducts that are there, and I've highlighted in round. These are the ducts that had epithelial proliferation that was filling the entire duct space, and that caught my attention on low power right away. And you can see some dilated ectatic ducts in the periphery as well. So if I zoom in on these two lesions, you can see where my difficulty was. Okay, this is another slide, and I'm showing you. Let me see if I can see which is. Most of these lesions are also showing some kind of epithelial benign proliferation. As you can see, 4 or 5 ducts that are expanded, and you can see that they are filled and there is no white space, meaning no free lumen is seen in these ducts. And if you go to there's one expanded duct at the left-hand corner in the left bottom. Okay, so there was a proliferation that was happening to me. I felt these were all looking kind of benign proliferation, but there was another larger duct was there which caught my attention. Next slide, please. Can we go to the next slide? Yeah, here you can see a duct that is expanded. I have put a blue arrow next to it, and this was what was worrying me to see what exactly it was. And you have to remember that we are looking at a 3-dimensional tissue in 2 dimensions. We always have to factor in that there is a 3rd dimension, and the slant sectioning can throw us off guard, and we can call these lesions slightly more aggressive lesions. So this one, I call it as atypical ductal hyperplasia, but the ATP was far too much. And the difference between ADH and DCIS is basically the size difference. Okay, so if it is 2 millimeter size, we call it goes into a DCIS category. If it's less than that, ADH is the definitions for us, if you look at the textbooks. So in this case, I felt there was a lot of things were happening. What it's not just the ADH that mattered to me, what other ducts were also doing was bothering me. And you can see on the left hand side, there was columnar cell change. There you can see some apical snouts and everything. So I made a call for ADH bordering on this one, DCIS, because sometimes what happens, we don't know the patient's follow-up data. And if I call it ADH, it may get lost. And so I call the pathologist, call the clinician and radiologist and have a discussion with them. This is how it is going to be. Is the patient going to be on a regular follow-up or not? So these lesions, sometimes they are followed, sometimes they're taken out, depending on the patient demographics. They are not able to come, they're coming from different places. So this, if you go to the next slide, I show you a close-up shot of this one. Next slide, please. Can you go to the next slide? It is just a, there's one more. Yeah, you can see now here closer. Okay, you can see that it's almost becoming cribriforming. And you can see some, one, I see the slide, I find one or two normal duct epithelial cells, then combine and then measure the size of the nuclei that are present in the other regions of this expanded duct. So this, to me, I felt I should raise the bar to ADH bar DCIS. So this was one duct and adjacent several things were proliferating. So I gave a call saying that this is atypical ductal proliferation and bordering on DCIS. That was what my final interpretation was on this case.
So Divya, you want to go ahead?
Yes, ma'am. So we got another opinion from a pathologist, and one of them opined that it looked like a typical ductal hyperplasia without any DCIS. Another opinion was that it is a tangential sectioning of UDH in a fibroadenomatous lesion. So finally, we advised her observation and regular follow-up. And recently, she came in January 2024. She's doing well clinically. She is normal, and MR mammogram also showed there are no adverse changes since the baseline imaging.
Manjula here. I just like to come in at this point. So
sure.
before
Manjula, before you start, I'm just going to raise 3 questions which I'd like you to answer, and then I'd like to take to the panel also. Is one, how comfortable are we when there's ADH bordering on DCIS to even if there are multiple opinions which then say ADH, sort of keeping it on close observation. 2 is, as a pathologist, when we know it's 2 mm versus 3 mm, that's technically semantics, according to me, of size. So where does one, as a clinician, decide when to bring in tamoxifen, when to discuss radiation. And Dipali, I'd like you and Shona madam to weigh in on that. And of course, the third question is, and that's just something I probably missed in the beginning, is Manjula, despite a benign biopsy, why did you choose to excise the lesion?
Okay, so addressing the first, so I'll actually address your second question first. Now, it was a benign biopsy, but it said papilloma, and she's been symptomatic for the last 3 to 4 years with consistent nipple discharge, which was increasing, and that was a cause for concern for her. Moreover, there were two reports from outside, from Apollo, I think Dispur and somewhere else, where they had called it a Birat's 4 lesion, and at our center as well, I had gotten two radiology reports done, and it was bordering on being suspicious, which is why we decided to do a microdecectomy and take off the papilloma as well. Now, that was why I went ahead with the excision. The nipple discharge continued to bother her. The second thing, which was why I was going to come in, was before we took two opinions, the fact that it was ADH bordering on DCIS, like you said, is just semantics. So we discussed it in the tumor board as to how do we go forward with this. There were two concerns. One, do we do a sentinel lymph node biopsy? Do we explore further? Because we've done the best possible imaging. We've done an MRI. The second thing was, do we offer her radiation, and what about systemic therapy? So of course, in the tumor board, we decided to actually, offer her radiation, have a discussion with her, and also explain to her that this is what we are concerned about. That could be ADH, which is a high risk lesion. However, it could also be bordering on DCIS. And then finally, once we had the discussion with the patient, now this patient is from Guwahati, right? And lower middle class to middle class. So after having a detailed discussion with them, it was their choice to actually decide not to go ahead with any further treatment, be it systemic or otherwise. And which is why we kept them in very close follow-up initially, once in 3 months. And then after a year, I changed it to once in 6 months, and she's doing very well.
Karen, did you all consider tamoxifen at any point?
Yes, it was discussed in the tumor board. Again, that was an option which I offered her as well. They were not willing.
Okay. Shona, any opinion on when you would want us to follow these patients up with tamoxifen?
So I think she's raised a very important issue. So the data all shows, and everybody's aware of all the trials, 100,000 patients, several meta-analyses. We know that the invasive breast cancer risk is down by almost half. But this data is a little confusing because there's no associated benefit in breast cancer mortality or all-cause mortality. That is the data side of it. The practical part is the uptake is very poor. Even if you look at adjuvant therapy, it's a struggle to finish 5 and 10 years of tamoxifen, to finish those 7, 8 years of AI. We're dealing with so many side effects. Everybody's running to do endometrial thickness. Gynacs are panicking when they see anything more than 10 millimeters. So, and the patient is really not willing to undergo all those arthralgias and constant monitoring. So I haven't really come across situations where my surgeon has sent me the patient saying, this is a high-risk patient, kindly consider prevention, chemo prevention.
So,
Saying
Dr.
that, maybe
Sorry.
5 mg TAM would be an answer for these patients,
Okay, so
because
what we
there is
call baby
data to
TAM.
show baby TAM for 3 years will not carry the risks of that kind of thromboembolism or uterine or whatever. So maybe that is an option, but I haven't had much success or experience with this.
So, Dr.
Ma'am, Dr. Shona,
Yeah.
if,
Go ahead, Priscilla.
sorry, just wanted to ask, in case if we do start, say, 5 mg TAM, again, what is the duration we consider? 2 years,
3
5
years,
years?
3 years, 3 years. The data is for 3 years. That was the study that was done of low-dose tamoxifen. And that seems to be quite safe and effective as well. And since you don't get it in 5 milligrams, right? What you would do is 10 milligrams every alternate day.
Break it in half.
Yeah.
So, Dr. Vani, and then I'm going to go to Geeta, and then I'm going to say something.
So I agree with Shona completely. When it comes to prevention trials, and if you've looked at it, the toxicity with tamoxifen is also very high. Obviously, the low dose or the baby tam has become one of the fancy stuff that you can use because it's a lower dose and it has benefits that has been seen. But more than that, I think if it is going to be a frank DCIS, I would err towards giving them tamoxifen and convincing them. But if it's an ADH or a high risk lesion, I probably will have to discuss with the patient all the toxicities laid across and then decide on giving versus not. And again, age of the patient will also matter because she's postmenopausal. There are more toxicities with tamoxifen in the postmenopausal age group. Premenopausal, probably you can consider, but again, all of these have to be really discussed with the patient, and it has to
Absolutely.
be.
And maybe lifestyle factors, modification is a more sensible approach in these patients.
So, Geeta, you've said 5 or 10 should be the dose. I'm going to ask how many patients have you been able to put on it?
I've done none.
That's the point.
Yeah,
That's the
and
point I'm making. See, text.
you know,
From
and the other
literature
thing
we
is,
have-
if you look
yeah.
at the NSABP P1 trial, it says all proliferative lesions.
Yeah.
So when you say proliferative lesions, it's not
They're
just
all
DCIS, it's
exactly.
ADH, your sclerosing adenosis. All of these fit into the your flat atypias. I'm not sure if flat atypia exists, but yeah, but all of ADH and sclerosing adenosis certainly. They say it gives 80% protection. That is what is the trial. So NSABP1, that is what it says. So, but I have not been able to get my head around, for an ADH, and usually you'll get a focal ADH, so it is 2 millimeters, 3 millimeters, and you keep wondering whether it is worthwhile trying to put this
So
patient
something like
through.
this, would we really want to put the patient through tamoxifen, even if it's baby tam?
Yeah, and the other question that I was thinking about is this RT. So now you said
So
it
I'll
is.
ask you why RT. So I'll tell you why RT, and that's what I'm going to get Dipali to weigh in. Not that Dipali was involved in the case, but I had a patient with a 3 millimeter focus. Now, because it was 3 millimeter, it got called DCIS, right? I chose not to do a sentinel node saying it was anyway a screen detected lesion, blah, blah, blah. 3 millimeter, my margins are clear. She went and took an opinion outside and got told to have formal hypofractionation 3 weeks in Bombay City.
So
Okay.
I recently had a
She came
patient.
back to me and I got both Dipali and Sandeep involved. And Sandeep Day, I remember, met the patient and said, please go away. So the thing is, the point I'm trying to make is, and that's what I want Dipali to weigh in on as a radiation oncologist is, technically, and Dipali, you're going to hit me later for this, is the way we look at it as a radiation oncologist will radiate even a plant pot if you put it in front of them. So now the point in reality is, when do we actually send these patients to the MDT to discuss that forward?
So for this is a very controversial issue to add radiation or not for this patient, because these are only quantitative changes. From ADH, it will convert to DCIS only quantitatively. So in such scenarios, treating that patient with radiation, giving cardiac toxicity, lung toxicity, that is like very intense for that patient. And many of the times we have to think more for treating such patients rather than treating the frank invasive cancers. So at this point of time, if it is low grade or ADH, the role of radiation is very controversial. And if the patient is anyways going on chemo prevention, that radiation should not be given. But if the patient is high grade DCIS and the palpable mass is there, then definitely there is a role of radiation, as shown by the IPOG.
So Dipali, I'm going to ask you, what is your limit of size where you would, for DCIS, say, could avoid radiation?
Okay, so if it is like screen detected DCIS plus less than 10 millimeter, or it totally removed with at least 3 millimeter of margin, so that can be excluded from radiation.
So guess who's getting?
So I need to come in. Yeah. So I was so I recently had a patient. She was a 3 centimeter cystic lesion with just about 5% of the inside was DCIS. The largest focus being 2 millimeters. Do you think I should irradiate this patient? Sorry?
Then as per the pathologist, it should be called ADH if it's 2 millimeter.
No, 2 millimeters is the size of the DCIS. So they said, see, ADH also, again, I think you talk about 2 ducts. It is not 2 millimeters. It is 2 ducts. More than 2 ducts, you would say that it is DCIS. Is it, you may correct me if I'm wrong, but this was called DCIS, an intermediate grade.
Geeta, I still feel those 2 ducts and 2 millimeters are semantics.
No, fair enough. So
No, but this
that's
is
the thing.
clearly DCIS. So, you know, I think the layers of cells also tells you something whether it is DCIS or ADH. So, but anyway, this was called DCIS, intermediate grade, 5% of a 3 centimeter cyst. It was a cystic lesion, and just 5% of that, and the largest focus of that 5% was 2 millimeters. Would you irradiate this patient?
No, ma'am, because it is again less than 10 millimeter plus completely removed, and low to intermediate grade we can avoid. If
Yes,
it's
so you
high
know, you've
grade,
got the Lords, Loris, Comet,
yes.
and the Japanese study also, and we are coming to a consensus on these ones. But of course, this was palpable, but the palpable bit was the cyst, you know, but actually the DCIs was really small. So we have to be very careful while offering, you know, radiation as well, because, you know, it is not always that straightforward when the patient comes back.
And so often enough, these patients go and get opinions from a lot of places. And the few that trust you come back, have the discussion again with you. I was fortunate that that patient came back to us and the rest of our MDT agreed on it. But she could have possibly got radiated easily somewhere else. We've got I think we've got a question in the group, which Dipali, you can answer, is 40-year-old female, not high risk, had a palpable mass, intermediate grade DCIS of 2.4 centimeters. What would you suggest for her?
So if 2.4 centimeters, so it is like a large lesion. So in this patient, I would go ahead with the radiation therapy.
So could not agree more on that. And Vaishali is asked, Vaishali, you can ask your question though yourself, is after a microdectomy, how are you really sure that the margins are truly negative? Vaishali. In the group, not in the group.
Yeah, I'm there.
Go ahead, dear.
So my question is, because there are certain situations which I have come across that I've done microdectomy, oriented the specimen, but I was not really very sure whether the other ducts which I have left behind are not really containing any DCIS. So how do I make sure? The margins were reported to be negative, but I had this concern in my mind whether I've done a good job. Although the MRI and everything looked okay, and only the lesion which was there in one particular duct showed abnormality on imaging. So how do I go up?
I'm going to say tamoxifen zindabad there, but going to let Vani answer that.
Okay, so you know what? I feel that, you know, here you have to take a decision based upon your own clinical diagnosis, whether it was a single duct involvement. If you had all your imaging, including MRI, including ultrasound, saying single duct dilated with a lesion within, you've done a good microdectomy, you've excised it, but that comes up with a papilloma and a DCIS within the duct. Now, usually not a single duct DCIS. DCIS does not involve only one duct. It involves more than one duct.
Right.
If it is only a papilloma, you're good enough, your margins will be clear. And anyway, a papilloma or a papillary CA, you would still look at that lesion and you may want to cavity revise, but not excise the whole lesion. Whereas if it is a DCIS in the main duct, main mammary duct, I don't think DCIS can ever involve a single duct. It will usually be more than one duct.
So that is exactly what I wanted to ask. So in this situation, should we go ahead with then major duct excision?
I think a major duct excision is warranted in this situation if it is a frank DCIS.
So, you know, Vaishali, depending upon the age of the patient also, if somebody who's, you know, even if it is a single, so, you know, your pathological discharge is usually a single duct discharge. The multiple ducts don't mean anything. So if it is a single duct discharge and it is an older woman, I would almost always land up doing a major duct excision.
So, but
why
if
do you
it
want
is...
to spare the ducts? Why do you want to do it?
No, I'm talking here about a young lady.
Younger patient, okay.
Where
so
you've
younger
done
patient is a tough ask. So like Dr. Vani said, in a younger patient, the chances that, you know, there would be other ducts involved is higher.
Go back in?
So in that situation particularly,
Go
I'm
back
asking.
Yeah, in that case, you should possibly go back and get it
I
out.
think most of us would, Vaishali, just for the fact that, like she said, once there's DCIS, the duct per se is what you've excised. You've excised that little base of breast tissue.
Yeah.
Most often, the pathologist will report the duct margin on the top. They'll report the base as free.
Right.
Very rarely are they going to tell you the sides of the duct are clear.
Correct.
Correct. You're always going to want to go back in and sort of clean that area up with that.
Exactly.
Okay.
Not only that, duct involvement is never a single duct in DCIS.
Fair
you
enough.
cannot have a single duct involvement. Papilloma, I can understand, but a DCIS cannot be a single duct involvement with DCIS.
So regardless of the age, then probably a re-surgery will be done.
Yeah,
So, it may not, it may be.
Hatfield may be a better option. In a older patient, a Hatfield may be a better option.
Start with a Hatfield in an older patient because that way your sort of index of suspicion being higher with them.
Correct.
Not particularly looking to save
So,
those.
so I also think it may be a single duct, but you must realize that the ducts kind of arborize into the breast. So there are multiple generations which are going into the. So actually we don't know whether you've tackled the problem at all or not, because you could have DCIS closer to the. But if you've got skip lesions beyond that, there is no way to tell.
Yes. Agreed.
So Megha, I'm not going to answer your question right now because we're going to have a very another entire panel on DCIS microinvasion. Tanuja will kill me if we discuss most of that without her here. So we will be addressing your concerns related to DCIS with microinvasion then, and I'll request you to wait for that. So Shalaka, are you online? Just because you did comment about the COMET trial. Yeah, so if you can just sort of run through bits on the COMET trial that we have data for now.
So the thing is, since the discussion was about low-grade DCIS, and we discussed this today in our journal club, our SR presented, and the data really says that giving endocrine therapy alone may actually bring down the risk of development of invasive cancers. So when they had upfront surgery, in one arm, there was a lot of issues in the trial. Honestly, it's got a lot of crossover. It has got some patients, actually half of the patients who were supposed to be operated chose active monitoring. So it's a trial fraught with a lot of issues. But having said that, the patients who got surgery, 8.1% had low, invasion also within a biopsy of low-grade DCIS. So 8.1% had invasion, and the trialists had already said that if the invasion in the surgical arm is more than 10%, will stop the study of observation. So they were expecting to have less than 10% cases with invasion, and they found 8.1%, which was fair enough. And then in the other arm, which underwent only active monitoring, only 3.1% developed cancers. Of course, that again, I said like the trial has issues, and I think one of the major issues is the follow-up is 2 years. So the reported follow-up is 2 years. And I think it may be a little too early for low-grade DCIS to develop into an invasive cancer at 2 years. But the point here is that endocrine therapy alone, in the other arm, in the active monitoring arm, I understand the problems with endocrine therapy that patients are not compliant with it, but that brought down the risk of development of invasion. So it's a very effective therapy for this ADH low-grade DCIs, whether we consider baby TAM or the full dose. The problem with the baby TAM study is that they didn't have an arm which was 20 milligrams. So they had an arm which was controlled, which was 0. So 0 versus 5 was compared. So it's like saying that trastuzumab they do at least 3 months, but nobody has compared it, and 1 year remains standard of care. So for me, if I intend to give tamoxifen for symptomatic patients for DCIS, prefer a 20 milligram unless the patient comes back and says that, I have symptoms and I would like to take a lower dose. Starting with a lower dose, the lower dose has never been compared with a higher dose. So
I think the lower dose discussion is more just for a group which is ADH, sclerosing adenosis, etc. High-risk lesions, not so much on DCIS. My other concern with COMET, other than the fact that, of course, it's got really ridiculously low follow-up of only 2 years, is that active monitoring of every 6 months, repeat a mammo, repeat biopsies, potentially, if you start seeing changes in that, has a very different anxiety level when you talk to patients in a clinic practically. And I'm not sure how we'll be able to adopt that into the clinical space.
Fortunately, we don't see so much low-grade DCIs and so much screening. Yeah.
That is the thing. So does anybody else see their patients jumping in on this, being willing to discuss that versus smaller excisions, which can potentially just remove the tumor from the space?
I think that, screening, the major fallacy with screening was the same, that you pick up DCIS, which you don't know as to what it is going to become later. So low grade versus high grade or whatever. And anxiety was one of the biggest problems there. So if you have a low grade DCIS that you're going to be monitoring, like Nita just pointed out, you will end up in escalating anxiety much more than anything else. Isn't it easier than to just get it out and have a diagnosis rather than just monitoring it or just,
So I would feel that if you're talking to a patient in the clinic, often enough saying every 6 months we'll look at it. If it increases, we'll rebiopsy it. If it's a small excision, many of them may just agree to that. One last question, which maybe each of y'all can say what it is what is close observation?
6 monthly.
So
No,
why is it? So when do you decide it's 6 monthly versus 3 monthly versus how long is the 6 monthly going to go on?
6 monthly for life.
No. Shalaka, hold on. So I feel that it is more again on the clinical degree of suspicion.
Okay, so
If
Manjula's
a lesion
case.
is called ADH.
Manjula's case came back as ADH bordering on DCIS.
I would look at it in 3 months' time clinically, but imaging and all would be 6 monthly, not more than that.
What imaging at 6 months?
In her case, if surgery and excision had not been done, you have to first do an ultrasound itself, which will pick up the lesion increasing in size, one. If there's a calcification, a mammogram. I wouldn't go on to an MRI. I wouldn't go on to
So this got picked up primarily on, so now it's excised. And you potentially don't know whether there was DCIS in it or not. Now, how are you following her up?
I think it will still be a clinical examination and mammogram will be an annual mammogram. If you have excised it, you have an area which is looking like DCIS, but you did not find it convincing enough to even to do a sentinel node. Correct? No, in that situation, I'm going to just do a mammogram annual, clinical examination and an annual mammogram. I'm comfortable. Manjula, are you?
I don't know, Manjula is still there.
Ma'am, will you prefer to review it again or you're okay with one pathology report only?
No. So most of these.
I'm assuming it's been reviewed and convinced and you've made a decision on observation.
So most of these controversial ones, Dipali, I think most of us send for a second review, get a consensus on whether we think it's ADH or DCIS. So unfortunately, both of Manjula's ADH.
This patient was 32 years old and very dense breast. So we repeated an MR after 1 year. I didn't repeat any imaging in 3 monthly, 6 monthly, just the clinical examinations.
Exactly. I mean, see, when I say mammogram, I'm assuming that you can see it in a mammogram. If it's a dense breast and you're going to miss it, then it will be an MR. But again, err towards doing a mammo first rather than to do an MR as a standard.
So I think that's the other concern, when you see high-risk lesions that have not been excised, how often is often when you're calling them back to the clinic? And often enough, it's going to be clinical evaluation, making sure there's no symptomatic concern, and or doing an ultrasound at 6 months, like both Geeta and Shalaka said, or doing an annual mammogram. Neha, you want to just add to that? Hi, Neha.
I was just writing on chat because I'm not really in the panel, but I couldn't stop
the
writing.
panel is just to guide us. It's all, everybody's just having a discussion.
No. So my point here is we are anyways looking at low grade DCS, which itself we don't know will ever manifest or cause anything to the patient, and going ahead and doing more aggressive and more intensive imaging is just going to keep picking up subclinical disease. So I would agree with ma'am that my first option of monitoring this patient would be clinical examination and the bare minimum imaging, which would be mammography, MRI only if it is very dense, so that if I'm not able to see anything, not more. MRI would not be my first choice in this patient.
Sounds fair. So Divya, thank you. Manjula, thank you. Shushma madam, thank you. We're going to jump over to the next case, which is
Can I Dr. Nita?
Sorry? Yeah, Trupti.
Can I? Yeah.
Yes,
so
please.
This case, actually, when I look at it, I was more in favor of usual ductal hyperplasia. I was just listening so much like
This is the problem. The pathologists only confuse us.
Oh, no. So if you say very high rate of intra-observer variability when it comes to UDH, ADH, so that is why I wanted to ask, wherever it was reviewed, was some IHC of CK56 and ER done or not? Because there is just one.
Manjula ran away.
So why I'm saying, because so IHC will not help us.
Sorry, what was the question?
So I was
sorry,
asking
I'm
whether
traveling, so voices are breaking.
I was asking whether CK56 or ER was done or not on this lesion.
No, it was not done.
CK5/6 and ER, I think, was done. Dr.
We
Sushma,
didn't
it
do
was
it.
done at
Yeah.
APCC, wasn't it? And the reviews,
Yeah.
it wasn't done.
Yeah, reviews, it was not done. We did it here. Yes. It was,
Yeah, in the reviews, it wasn't done. We got
wasn't
two
done.
reviews, one from the southern part of the country and one from the states.
So was it like very homogeneous? Because this is one area where I mean differentiation, like whenever you see any amount of duct involved, like obliterating the lumen, if it is high grade, there is no doubt about it. Then you don't see whether one duct, two duct, any high grade necrotic, it will be a high grade TCS. Problem comes with low level of atypia. So in this, if ER and all is done, it's fine. Otherwise, it is very tricky. Like even on morphology, I will be more towards UDH in this case, unless I see that ER is homogeneous, strong, and absence of CK56.
No, we did on this case. That is why we went ahead and did, because there was a little bit of a dilemma on this one. Hence, we went ahead and did it. That is why I call it as ADH bordering on DCIS.
It would have been great if we could have put the picture of IHC on here. Just
no. What I'm saying is that you can have ducts partially involved also, where part of the duct may be still having its normal, and then you can see a evolution of the DCIS happening, and depends on what point we catch it. So all ducts may not be uniformly involved, and there may be partial involvement. Many times we have seen in the breast biopsies and the resections, it is not uniform. So you can still have a normal duct epithelium that is pushed towards the center, and there will be underlying proliferation coming about. So you can, this is where I told it's a landmine, and depends on who sees it. And if there is a residual tissue that is there, still you will find some amount of CK5/6 positive cells will be there. But how will you take a call? Will you see the area diffusely that is lacking the CK5/6, whereas the normal portion of the duct which is still uninvolved, it's still retaining the CK5/6? These are fine lines drawn. So you have to step back and see what the entire picture is happening in the remaining ducts too. There is proliferation happening in other ducts as well. Okay, so that was what caused me unrest in this case. We went ahead and we did it actually, and then we did see a loss. And that is where I drew the line, because these are very fine lines and we need to be more objective rather than subjective in these cases. So this case we had done. I'm sorry I didn't get the slides, and next time when we will definitely do it and show it across to you. This is my first participation in the group.
I'm going to actually stop the conversation here because we're going to jump to the next case.
Nita.
No. So the one point I'm going. Yes, madam.
Okay, both Sushma and Tulsi in one line. You have a control which is ER expressing, right? Control will always be ER positive. You have PTH which is ER positive. How much will you jump and say I'm going to give tamoxifen?
Sorry, I didn't
No,
understand.
so even if your control is positive or the ADH is positive, the pathologist is going to send it back to the clinician saying, you decide on the
You decide.
Exactly.
So we will just quantify whether in that involved duct, whether it is strong diffuse versus it is heterogeneous. So more than this, when it comes to it is more helpful from a diagnostic point of view, I would say.
So since I'm going to say B3 lesions are primarily a diagnostic dilemma more than a treatment, I'm going to let Palak have the last word, and then we'll move to the next case.
Sorry, sir, not a last word, but a question. We can cut on the second case. My question to the surgeons is, what is the incidence of B3 lesions that we see in your practice? Like, let's say out of 10 or 20 patients, how many of them would have such diagnostically challenging cases? Would it be 1 or 2 out of 20?
It increases with screening, Palak.
Yeah, I see more now than I used to see in TMH.
Exactly. So it's
I was
increasing
more clear in
all of us
TMH.
with, and honestly, I'm quite lost. I think I know
Palak,
very
I
well.
keep sending them to you only, no?
Yeah.
Yeah. So, ma'am, the reason why I'm saying is, I may be wrong, but what I'm just suggesting is that it is these cases where we probably need, if we are going to keep somebody on a follow-up with a very tricky situation, the reason is we don't want to miss a cancer. I would personally suggest to do an MRI, maybe 6 monthly, and up to 2 years, if stable, which is following the BIRAD's recommendations, and post that maybe annually, because they are high-risk cases. they do fit in that norm, irrespective of density, unless it is a B3 associated with microcalcifications, mammo would be good. But for a non-calcific situation, even in a non-dense breast, we do see findings on an MRI. Now, I'm not asking to act upon every MR. The MR here would serve as a baseline. And after 6 months, if we see a suspicious change, that is when we intervene. And if we don't, we ask her to remain stable. So that's just an opinion, but
I'm going to just say something there, Palak, is that's when we've not done the excision. So like with Manjula's case, fortunately,
agreed, agreed. Yes, yes, yes. If we are not excising something, multiple findings.
Right. So
yeah,
she's
and
done
don't
the
work.
excision. She's clear on what it is. It's just there where we're sitting on the fence of whether it's ADH or DCIS. I think 1 year was fair for that. Something that we're leaving in situ and following up, we may want to be a little tighter. I'll be honest, struggle with 6 monthly MRs. So I do an ultrasound 3 monthly on these patients currently. So we're going to actually jump across. Fabulous discussion, everyone. Great case, Manjula.
Thank you.
Thank you so much for helping with this. Shalaka and Divya, if you all are here, if you all can take over on the second case, please.
Divya.
Yes,
Divya,
yes,
probably
ma'am.
think
Can you
Shalaka.
hear me?
Yes, Divya.
No,
go ahead.
no.
And there's your slide.
Yeah, good evening, everyone. This is a very interesting case, actually. This is a 44-year-old premenopausal lady with no family history, no comorbidities. She presented with a left nipple discharge since 2 months, which was serous.
Sorry.
No problem. Which was serous, spontaneous, and scanty. And she was complaining of a left breast lump since 1 year. The patient had an MRI done outside. I'm sorry, we don't have the images of that. Suggestive of multifocal lobulated enhancing lesions, with few of them showing irregular and partially circumscribed margins in both breasts, with few of them appearing to be intraductal papilloma. She was advised biopsy outside. The biopsy was done from the right breast 10 o'clock and 5 o'clock lesion, which was intraductal papilloma with low-grade DCIS. And the biopsy was also done from a left-sided 2 o'clock lesion, which was also intraductal papilloma with usual ductal hyperplasia. We repeated an ultrasound for that patient. Right breast showed a lesion at 9 to 10 o'clock and at 5 o'clock. The lesions were biopsy-proven papillomas with DCIS. The other right breast lesions at multiple locations at 11, 12, 2, 6, 8 were also showing similar morphology as the 5 o'clock position lesion. The left breast 2 o'clock lesion was also a biopsy-proven papilloma, and it had other lesions at 4 to 5 o'clock and 5 o'clock, which were suspicious of intraductal lesions. So we got a review of those biopsies at TMH. All of them were complex papilloma with usual ductal hyperplasia and no DCIS. Next slide. So this is the initial core biopsy. We were not able to comment on the IHC status of these. So we decided to do a sonologue excision biopsy of the bilateral breast lesions. These were the markings. So the patient underwent sonolocalized excision biopsy of all the lesions. The periareolar excision was done for left breast 1 to 2 o'clock lesion with additional left breast retroareolar 2 o'clock lesion, and right breast 10 and 5 o'clock lesions were excised. All the lesions turned out to be intraductal papillomas. So these were ERPR negative, and there was no DCIS even in the final biopsy, final excision specimen. Since her HPR was intraductal papilloma with no evidence of DCIS or invasion, the patient was kept on observation and was advised an MRI surveillance at 6 months. Next slide. So this was her MRI done at 6 months, which was showing multiple enhancing lesions in bilateral breast, similar to the morphology of the previously seen lesions. This is the subtracted images. So the follow-up MRI done was...
Divya, one moment. Could you go back to one slide before?
Yeah.
So these are subtracted images, and I guess some of these are ultra-fast images. So we often use ultra-fast images to try to differentiate and try to catch the more vascular lesions and suppress the background parenchymal enhancement to some extent. So it just helps us to triage better. Yeah, please continue.
I have a question, Palak.
Yes, ma'am.
Do you resort only to MRI, or would you have contrast enhanced imaging also as one of the tools in these situations?
In these situations, only an MRI.
Because B3 lesions, so better to go in for
Because B3, the specificity needs to be very high. They're often multiple. The three-dimensional anatomical localization between multiple lesions is often needed versus a superimposition on a CEM. Non-mass enhancement will be seen better. And especially now that we have the ultra-fast sequences on MRI, it helps us triage. At least we are about 50% better, I can say, than the routine post-contrast imaging. And a CEM still essentially is more like a routine post-contrast imaging. So whenever there are multiple lesions or a diagnostic challenge or B3, I would always recommend an MRI.
So can I just comment to Palak? Hi, Shalaka here.
Hi, Shalaka, bolo.
So I agree with Palak. This patient, just to give you a background, Divya has told you very well. I had also forgotten her exact history. But honestly, there was a lot of concern because an outside surgeon had told her bilateral mastectomy, robotic or nipple sparing or whatever with whole breast reconstructions. And she's a SOBO patient. So that is South Bombay. Nita knows very well. So basically, there's a pair of very anxious patient and her husband. Very pretty lady, of course, all are. But the point is that she was super anxious about his multiple lesions, and somebody told her bilateral mastectomy with implants. And super thin lady, so no DIP or nothing else possible. She would directly need an implant, that kinds. And when she came with an outside diagnosis of DCIs, the first and foremost thing was the slide block review for us to understand. What is it really DCIs? And like our pathologists, and we discussed this in RADPath also meeting, and I actually pushed Tanuja madam and Palak to discuss this with me on a very impromptu kind of a situation. So I pushed this case because I wanted to talk to the lady the next day. And they told me that, okay, there is no DCIs for sure, and these are just complex papillomas. So mammo was very dense for her. So there was absolutely no point doing anything on mammography as a follow-up. So she needed either an ultrasound or an MRI. And of course, I guess since there are multiple papillomatosis like situation, when I did the excision biopsy, she was worried about scars. She was worried about number of scars on the breast. She doesn't want tamoxifen because she's worried about endometrial cancer. That's a classic patient who has got anxiety all over her written. And these kind of patients, you need to actually, you may have to make a decision based on their anxiety also, more than just what the protocols say. So we did an MRI. And Divya, go ahead and present the next because their story is not yet over.
Yes. So on the first follow-up, when we got her MRI done, which was showing multiple enhancing lesions in bilateral breast, a USG was suggested for targeting biopsy again. The USG was also suggestive of multiple bilateral lesions, BRADS 4A. And since a lot of lesions had been biopsied, we decided to do a WAB of the 7 to 8 o'clock left breast lesion, which was not previously sampled at least. So the WAB, yes, ma'am.
And let me be a very good radiologist in the surgeon's eye, because this is the patient where, yes, you can laugh because my recommendation was surgical excision. So this is what I would want to say, that the selection of cases has to be very precise. If I'm seeing like multiple 5-6 lesions in the lower inner quadrant on one side, I would really prefer a surgical excision and get all of them out. So my plan was to request for a surgical excision on the right lower inner quadrant, and left side, she had multiple biopsies. If you also remember seeing the image before, above, outside, and lower outer. But it was the lower inner quadrant, which was never addressed. So we actually went through mapping of all the multiple lesions, saw which quadrants have been addressed before, came down to 2 quadrants which were not addressed before, and then suggested a surgical excision biopsy from these sides. Next, what happened is, now the patient says that no, she doesn't want to undergo one more surgery. So the whole reason for going through a WAB was because it was driven by the patient not wanting to undergo another surgery. And one thing that, again, what we can tweak is, if I was targeting the left breast lower inner quadrant, we did describe in the report as well, they were not very far away from each other. So the plan is, in the single incision with the same needle, if they are close by, we can take multiple samples and try to get samples from at least 2 or 3 lesions which are around each other, not changing the cost of the needle, considering if either one of them is positive for malignancy, all of them have to come out. So that justifies the use of one needle because it is a single site entry, and try to sample multiple lesions in the same sitting in a small geographic area. And we placed it.
Absolutely. I remember this conversation, Palak, when you kept telling me, but believe me, a second surgery would mean almost a subacute mastectomy on her, because the area that was at, at risk was a lower inner quadrant. She was worried about cosmetic outcomes, and I would end up in a significant amount of resection. These are all impalpable. See, the first time I operated on her, everything was palpable. So it was
Right.
not very difficult to precisely, accurately remove. All of us may agree on the fact that whenever something becomes impalpable, we end up removing
Go
more.
wider.
So
Yeah, we go much
cosmetically,
wider.
yeah, so much wider. So
So
I
this was,
requested for a VAB,
and this
and
was
she
like
did
an
it.
extended VAB or a VAB excision where we nearly resected 3 of the lesions seen
Yes,
in
you
the
did my
yeah.
job.
Never as good as you. Please continue.
Okay. Both of you
Divya.
will talk about each other tomorrow. Divya.
Yes, ma'am.
No radiologists can ever give surgical margins. I owe it up. Thank you.
Go ahead, Divya.
Ma'am, can we have the next slide, please?
Okay.
So this patient, like discussed, was not willing for surgery. She underwent VAB of the left breast 7 to 8 o'clock lesions, which turned out to be complex intraductal papilloma with usual ductal hyperplasia. ER highlights the epithelial cells patchily was the report. And we had advised her for chemoprophylaxis, which she was absolutely not willing for. And we have started her on 6-monthly LHRH and to follow up with us on a 6-monthly interval with an MRI.
Forgive my ignorance, but LHRH is also being given as prophylactic.
So
No,
you
it's
can
not. It's
Where
not.
did this come up from? Which study, which trial?
No. She didn't take it in the end. She didn't
No,
take
she
it in
may
the
not have
end.
taken it or taken it,
Yeah.
but where
So
did
there
this
was a
come up from?
discussion. That's when Trupti I discussed with and Tanuja madam, and like what she was telling that it was heterogeneous ER. By that she meant that it was not completely ER positive. So Tanuja madam rather said that won't be surprised if it is a ER negative tumor that she develops. So she definitely has a higher risk of malignancy because of the multiple papillomatosis. So although a single intraductal papilloma is not a risk factor, not really an added risk factor for developing breast cancer, but multiple papillomatosis like situation like hers, peripherally located, not always central, not all associated with bloodstained nipple discharge, that is a relative risk of around 1.2, if not very high. It is a higher risk, and it doesn't, like ADH and ALH, warrant a complete chemoprophylaxis. So most people would end up observing, and that's what we are doing. But there was a discussion. She's perimenopausal. She is 44, already having perimenopause, and 2, 3, 4 years. So there was a thought at that point in our mind that if we could she asked us directly herself, maybe some advice outside somewhere, saying that should I remove my ovaries and would my risk go down? So that was something that she asked us, and we told her that no, actually, oophorectomy per se won't help. There was a thought of considering giving her Zoladex for ovarian suppression, but then with the knowledge from Tanuja madam and Trupti and that MDT that it's a heterogeneous ER/PR, ER expression, and this kind of case. You also did one more marker, right, Trupti, for
So,
her? I'm not remembering.
in brief, Shalaka, this is experimental treatment that you started.
Oh, for sure. So I'm going to throw something into this mix, which is that let's say your patient has significant family history, same patient. You get a genetic testing done on her. Now, like one scenario is where she's got no pathogenic variant. One is where she has a low penetrance or intermediate penetrance.
VUS.
Yeah, no, not a VUS, an intermediate penetrance pathogenic variant. Okay, let's say an ATM, which is not known to be of high penetrance. Would this change your plan in any way? Would you be offering her something differently?
Well, so that's like opening a Pandora's box.
So
And
unfortunately, that's clinic.
yeah, no, I would just keep her on surveillance and I would do nothing. There was a thought of giving her tamoxifen, but I think Trupti, would you want to tell us about the marker that you did? A
No,
particular marker? I'm not remembering the name.
I think some confusion because I was just telling that it is a papilloma with usual ductal hyperplasia. There is absolutely no atypical hyperplasia, no DCIS, nothing. It is like a benign papilloma. The only risk factor here is that multiple papillomatosis peripheral, which has
No,
little
but there was
higher
a genetic study you did now on that.
genetic study. I don't remember.
There was something else you did on that.
Must have
Oh
done
no,
some
that's
IHC markers, or must be the other case, Shalaka.
What did you do? 5, 6?
No, so actually here I feel there is no indication for any chemo
I
profile.
think Ayushi talks about osteopontin. Isn't that the one?
This case, I really don't remember.
This case wouldn't do, but isn't there a marker called osteopontin where you can understand in the papilloma the risk of development of cancer?
Yeah, there is, but for this
Experimental
case,
still.
but we have not done on this case.
You've
The
not done. Okay.
no,
Okay.
no.
So
ideally,
while
it's
we are
like-
discussing, Nita, while we're discussing, I've had a 19-year-old that I saw in Actric, and she had like half the breast was replaced with some mass lesion, which you could not make out. We've done all imaging, and it turned out later on that she was nothing but multiple papillomatosis occupying half the breast in a 19-year-old. I did a generous incision biopsy, got that as because excision was impossible, came out as multiple papillomatosis. There was absolutely nothing else but papillomatosis. So we have observed her. She's been absolutely stable and fine now for 7 years. But the point is that this can happen. So there can be multiple papillomatosis which are there and no genetic risk, nothing, no family history.
So I'm just saying that let's say the patient has family history,
Then
right?
I
She
would
has
not-
multiple papillomas and she has family history. She's 47, 48, super anxious. Is that changing the way we're counseling her in the clinic?
I think it will, because here now you're looking at a background risk which is much higher. And she has a pathology with a proliferative lesion. And with even if it is a usual ductal hyperplasia, she's got multiple papillomatosis, which itself is again a high risk. So I think in this situation, chemo prevention has to be discussed. Surveillance has to be much more, vigilant. And then, of course, based upon what is the risk, if there are 2 members or 3 members in the family already having breast cancer, you would probably even talk about a prophylactic mastectomy, maybe.
So I'll tell you, I have a patient who multiple peripheral papillomas, comeback is just intraductal papillomas. There's no atypical hyperplasia, but her mother did pass away from breast cancer at the age of 50 something. She's 45 odd. Very, very hyper. Genetic mutations are negative, pushing for a surgery where I have said, I don't think it's something that I think you deserve right now. Stay on surveillance. I know she's going to go to the next surgeon who's going to offer her bilateral prophylactic mastectomy.
We know that for very clear, Nita, that if there is a patient who is so anxious that she is hell-bent on it in spite of counseling, in spite of explaining the risks and everything, then I guess we are going to go with what the patient says.
So would anybody else want to weigh in on this? I mean, how far are we willing to let the patient decide on the anxiety of the patient drive prophylactic surgery?
As
So it's
long
very
as she
easy for
has
us
all
to
the
say
indications.
surveillance. No, so she's mutation negative, just has multiple papillomas and is
that
anxious.
should be more counseling.
So that's what the thing is, So
more
would anybody else want to weigh in
She's
on that?
genetic mutated. She has only papillomas. Mother died of breast cancer. I would probably know her towards whatever she wants, because here.
No, I'm saying no mutation.
Yeah, no mutation. I would say surveillance only.
Anybody else? Any other opinions?
I think at the end of the day, it is patient's choice. You have to tell the patient that your risk is, say, your relative risk is 3 times. And then for that amount of risk, if the patient is really insisting and with understanding fully that this is what the risk is, and if the anxiety is affecting her quality of life to that extent, I think maybe in selective case, it's okay.
No,
But
Neha,
the
then you
list
have
of
to have a
genetic risk
catalog of
1.2.
complications. Catalog of complications with prophylactic mastectomy should be ready.
I mean, after explaining everything to the patient, if the anxiety for this is affecting her quality of life to that extent, and you have tried to observe the patient for 6 months, 1 year, and the anxiety is not going away, I mean, eventually, maybe yes. Because there is a slight increased risk, ma'am. So I think in rarer cases, it can be patient driven.
So I just going to say that, there's no single answer. Palak, you were saying something.
No, I just said I have a non-surgical opinion here. As
Yes,
I see logic, I mean, there is a much greater risk of dying when we cross the road and we don't stop walking. That's the
So I
point.
tell all of them that. I always say when they ask
And my
me
point is,
100% of anything.
yes, so anxiety is one thing, but I think scientifically counseling somebody is another thing, because we don't know who has counseled or pushed somebody towards that unnecessary anxiety. It could be a doctor themselves. So I think it is our job to probably be scientifically as judicious as we can and counsel them appropriately.
Geeta.
I think, we tend to do so many, it's just because we do so many investigations that we pick up these extra lesions. And otherwise, these papillomas would have possibly died with her, whenever she died. So the thing is, we keep picking these things up, and we do know that multiple papillomatosis is an additional risk, but it may not translate. So here we are talking about low grade DCIs and intermediate grade DCIs, just leave them alone, follow up. That is the discussion that we're having on the sidelines. And here for papillomas, we're willing to sacrifice both breasts. It's like, sometimes I think it's an overkill. And sometimes I also think that we are also not really equipped to answer this very difficult question. But somehow I think, there are a lot of regrets, whichever way you look at it. So she can have a mastectomy, not be happy with her reconstruction, and the complaints will continue. And what have we added to her life? Have we added quality to her life? Have we made her any less anxious? If she's as a personality very anxious, I don't think we are really addressing that problem.
And are we also counseling about the recurrence post mastectomy also? There is that little chance of even that happening?
And I've seen that happen. Patient has had mastectomy and has recently had reconstruction. 3 months down the line, she has a tiny little nodule sitting in the upper outer quadrant.
I'm going to say something that got discussed at this time, St. Gallen's. And I thought that was very beautifully put by Armando Giuliano, where he said that to do a prophylactic nipple-sparing mastectomy means that you have taken out all the tissue. You have to core out that duct around the NAC. You have to have done a well-done procedure. Otherwise, you are not doing the patient justice. And that is associated with more morbidity, more complications. And that we all
And it
know.
was added that when we are doing a prophylactic mastectomy, all surgeons err towards a thicker flap, leaving behind some tissue. And that is completely accepted by everybody, saying that gives a better cosmesis. So we are going to end up erring towards thicker flaps and leaving breast tissue. So I don't see how we're going to be
we're really helping the risk. Absolutely.
Yeah, how we're 100% sure of a prophylactic mastectomy.
And with robotic, I would be even more worried.
Oh my God, let's not go to that conversation.
I agree.
We all know what happens there, and I think
so doing prophylactic under the guise of this robotic, I am very, very,
that's I think an argument for another day before Shalaka hits us on.
Yeah, absolutely.
So I'm just, Shabnam, are you here? You brought up a conversation about PIK3 mutations. So Trupti, do you have an opinion on that? Shabnam suggested that you can do PIK3 on papillomas. If negative, then risk is.
So similar discussion we had in this RADPATH meeting about PIK3CA. Tanuja madam is always excited about, but thing is that it can also be seen in intraductal papillomas, and exactly how much it will help us identify the risk is still under research. But this is one project that she is interested in doing.
So Tanuja is really going to beat us for not being here for this. All right, we're going to jump.
Just one point I would like to highlight. So this was like a very florid kind of intraductal proliferation, as you can see. And again, those two markers, very important, CK56 and ER. So ER heterogeneous is like a diagnostic. I don't think that ER directed treatment and all, it is suggesting, it is just saying that it is a non-clonal proliferation. There are some luminal epithelial cells, some basal epithelial cells. So that is what we prove. So sometimes in such cases, we don't see CK56, we see strong ER. So in that, the criteria for whether it is ADH versus DCIs, that is a very gray zone. And again, will create lot of confusion. So the criteria decided is 3 millimeter. So in a papilloma, if a confluent like linear dimension is 3 millimeter, more than 3, we'll call it papilloma with DCIs. In this case, there was everywhere, it was like a benign epithelial UDH kind of a proliferation.
Fair enough. So I'm going to say this, and I say this with a lot of love for all the pathologists in the system, but it is so difficult to just decide based on one pathologist's opinion. We've been privy to some of the best pathology in the country, but even with them, I think they've rediscussed it among each other before coming back to us with answers. So with anything that is controversial to this extent, I would always say, please go back and discuss this with your pathologist, try and get a second opinion. Divya, do you want to just run through the next one before we start winding up for the day?
Yes, ma'am. So this next lady, she's a 53-year-old postmenopausal nulliparous lady with no family history and no comorbidities. She presented to our OPD with a left breast lump involving the entire outer half of the breast with a 2 by 2 centimeter matted axillary node. The right breast and axillary examination were normal. She was diagnosed to be a left LABC ILC grade 2 880 with a MIB of 6 to 8%. Her mammo was suggestive of a left breast mass extending from 12 to 6 o'clock with presence of microcalcifications and with a 2.5 centimeter into 1 centimeter axillary lymph node. The right-sided mammo showed us anemia at 11 o'clock, which needed MRI correlation, multiple isodense lesions in all quadrants, and hypoechoic 1.2 centimeter lesion at 1 to 2 o'clock, B3, and another lesion lateral to it, which was 1.1 centimeter, which needed an MRI evaluation, further MRI evaluation. On PET scan, she had a left breast primary with a right breast very low FDG uptake in a 1.1 into 0.9 centimeter upper inner quadrant lesion. Next slide. So this was her mammo showing the upper inner quadrant lesion in the left breast and disease in the right breast. So the MRI done suggested left breast primary in the upper outer quadrant region with suspicious left axillary nodes. On the right side, there were multiple focal early enhancing lesions, largest measuring 1.7 into 1.2 centimeter with lobulations in the upper inner quadrant, which needed a biopsy correlation. We did a USG-guided biopsy of the right-sided 1 to 2 o'clock lesion, which turned out to be sclerosing adenosis with microcalcification within. Our plan is to do a left PCS with LD/left MRM plus DF with a right-sided sonologue excision biopsy of the other lesion.
So has the patient been operated or still being planned?
She was planned for today. I'm not sure if she got operated.
No worries. So I'm going to ask 3 questions here, and I completely agree with the concept of this is what Geeta brought up earlier also, is that even in sclerosing adenosis, you're going to want to go in and excise. I'm actually going to jump to that, let's say you had picked up LCIS because the other side is ILC. What if this side was LCIS? How comfortable would you be to say that, we pick it on frozen, reevaluate the other side? So Trupti, anything?
Can you please repeat
So we know that one side is ILC, the other side biopsy comes back as LCIS. If I want to now evaluate this on frozen section because my patient's having a mastectomy on one side, how comfortable are you going to be on frozen to give me an answer on LCIS?
Very difficult to comment on frozen section. That is for sure. But whenever you, as I said, so whenever we see LCIS on excision, I think the main thing will be whether it is classical type versus pleomorphic LCIS. And if it is you are seeing on imaging, if there are multiple suspicious, I think it is I think it will be your call, but on frozen, I will be very uncomfortable.
So I think that's the other point that we have to be very clear about, that there are certain things frozen cannot help us with. Papillary lesions is one of those. LCIS is one of those. So turning to the pathologist and putting the gun on their head is never the answer. We need to be able to make these clinical calls. And the second thing I'm going to ask, and this I'm going to ask the surgeons in the group is, if you have an ILC, which you've done a wide excision, there's LCIS on the margins. How wide is wide for you, and what is a negative margin for you there? I can see you smiling.
Nita, just one thing before everybody answers that question. This patient had a mastectomy and DF today, subacute mastectomy and DF, because she had significant amount. We got a topography on the MRI from the radiologist, and I wasn't comfortable because it looked like 45-50% of the breast in an ILC and margin issue. Yeah, and that's why she was posted in the microvascular OT, and they did a DF on that. And the other side, we did not send it for frozen, right? Anybody here who was in that OT today, did we send this for frozen? I don't think so, because it was sclerosing adenosis on biopsy. So we've just excised that area because it is sclerosing adiposis. And I think, as Geeta ma'am also said, we are also quite comfortable wanting to always completely excise the sclerosing adenosis. And it was luckily not LCIS for us, but we didn't send it for frozen section to the best of my knowledge.
Okay.
Like
Thank
I
you,
said,
Shalaka.
you're operating on one
Trupti, I'm your friend.
Yes,
So
yes, thank you.
lobular is something that I simply loathe. You could have been looking at these
Yeah.
small tumors, and then you would do a wide excision. So I would reserve wide excision for smaller tumors,
So 1
lobular
centimeter
carcinoma.
tumor has some LCIS on the margin.
So I'm not happy because I would try and gather as much information as I can from my radiology colleagues, because lobular is something that stumps you all the time, and you will always find that what you're seeing, feeling is much lesser than what it actually is.
I can
No,
give
so
you
now your
a
wide
story
excision is
on the
done. Your
lobular,
DCS
but the point
specimen
is
is
that,
back.
Anita,
Still has LCIS. Now what?
Nita, LCIS per se, we will still not consider as a reason for revising margins or doing mastectomies. It is one of the high risk features, but it is not a margin positive to get an LCIS. Let's be very clear on that. DCIS is a totally different ballgame. Even in a patient with an ILC, I would not err towards doing a mastectomy for an LCIS. Now, the second thing is, imaging may be absolutely normal. You can still have a invasive lobular cancer. Please remember, no matter what imaging, we have done MRIs have missed. So please remember that you can have missed diagnosis in a ILC on both sides, and you have to be, if you find a lesion, you have to send for frozen. If you find a lesion where it was not supposed to be, send that tissue for frozen, and ILC will be picked up. LCIS, I would not bother.
So, Dipali, would you change your plan of radiation in any way if the margin was positive for LCIS?
No, ma'am. For LCIS, even the margin is positive, radiation will not be recommended, only if the patient is going ahead with chemo prevention.
Okay, fair enough. Palak, you have your hand up.
So the LCIS, I'm okay. You're absolutely right, because LCIS is only a marker of a. But when it is in association with an ILC, I have to be sure it is not pleomorphic LCIS, because if it is pleomorphic LCIS, it has to be treated like a DCIS. And the other thing is, you may not find anything on ultrasound, you may not find anything on mammogram, but this is one situation where an
most of us
MRI
are
comes
doing
very,
MRI.
very handy, because a lot of times I've been surprised by what an MRI shows you. What you're feeling is only 1.5 centimeters or 2. And when you do an MRI, you find that there is florid enhancement going in different directions. And then, your decision becomes easier. And the discussion with the patient also becomes easier, because she is also feeling a 1 centimeter. And finally, what you get is a 6 centimeter thing,
No,
what is 1
that
centimeter?
MRI is your standard. If you have a diagnosis of an ILC, you are going to ask for an MRI, because contralateral lesions may be easily missed by standard imaging. But I'm telling you, I've had a patient where MRI missed as well. And on table, when we were doing reduction, I find these big lesions, and all of them were ILC. So I had to actually counsel this patient for a bilateral mastectomy from a reduction. So you can imagine what a step down or rather step up of the surgery happened. From reduction, bilateral reduction for a grade 4 ptosis, she ended up with a bilateral mastectomy and a flat chest. So you can
And it is very treacherous in the sense that you may be having the small lesion, you don't feel any nodes clinically, and when you actually do the sentinel node, you find that there are small nodes, 3 out of 4 nodes positive. You do an axillary dissection, 20 out of 25 nodes positive. So that is how treacherous an ILC can be.
Sorry,
so
Ankita,
the variant,
Das,
especially the
are you
aggressive
here?
variants, can have multiple node positive. We've had as high as 17, 18 nodes positive in which didn't look that bad.
True.
Sorry, Ankita, are you here? Can you give us a little bit on your paper that you presented with your experience on ILC?
Yes, ma'am. So, just because we did a data set, we audited the ILCs from 2016 to 2023, and we had about 566 cases. Of these, 425 were operated. So we had the histopath reports of 425 patients, And as I was doing the data, I noticed that in a lot of them, even with 1 and 2 centimeter primary tumors, we had 15, 20 lymph nodes positive, and in clinically negative lymph nodes. So I ran a correlation on them, and how in historically IDC has been shown to correlate with an increasing T size. It has a linear correlation with the chance of a lymph node mets. That does not seem to be true for ILC. The correlation coefficient was just 0.37, which is very poor. So my point that I made in my paper, or that I am making in the paper that we're writing, is that maybe we can't really apply these de-escalation of axillary surgery and trials like SOUND and SEMA, or even Amaros and Z11 for ILC cases, because they're highly underrepresented in all of these data sets, and clearly they don't follow the same characteristics as IDC does.
And what we know from literature also is that frozen tends to struggle with lymph nodes
Yes.
related to
Yes.
nodular cancer.
In our frozen section paper, also the one significantly higher false negative frozens were in ILC, because the ILC has a lot of discohesive cells because of the loss of that E-cadherin. So they look like lymphocytes, and hence on a frozen section, they might not often be picked up as malignant cells in the lymph nodes.
So they are very bland looking and sometimes in the subcapsular sinuses. So don't kill a pathologist if they miss on frozen, I would say.
No, we never kill a pathologist.
I know.
But no, but interesting thing also about Ankita's data is that 35% of our ILC was pleomorphic, which is not what the outside data sets are saying.
That's
I mean,
because we do palpable, not screen
yeah.
detected.
So 35% being pleomorphic, and they are the ones which are high grade. The other
That's
ones,
the point Gita's made, is that that's not been removed from the AJCC classification. That's still part of that. Palak, and then I'm going to two questions in the
So I was talking about this case. We were looking at two situations in the contralateral breast, either a sclerosing adenosis or LCIS. So we have had a core biopsy before. If it was an LCS, very rightly as Vani madam pointed out, if it was an LCIS, apart from what we see, actually you can have much more delayed enhancement and very rarely no enhancement at all. So maybe it is worth going in with wider margins if you're expecting an LCIS versus if your core biopsy has said a sclerosing adenosis. That's one. And the second thing is, if it is a sclerosing adenosis, we find a lot of them. Are we always excising all of them? I'm not sure.
So that's the question asked is, does sclerosing adenosis always need to be excised? And if we can observe it, how do we go about? So
But
Geeta,
let's understand one thing. Sclerosing adenosis on a core you're saying, right?
Yeah.
But
yes.
otherwise, it's usually the pathologist who tells you when you're widely excised and given them a suspicious
No,
B3.
so now the question is that, so now the question is that when you have sclerosing adenosis on the core, this patient was anyway undergoing surgery, so had the opposite side excised. Your patients in the clinic just has sclerosing adenosis on the biopsy. Are we going to go in and excise that? Geeta, would you like to comment on that?
Sorry, what did you say? I'm sorry.
So you have only sclerosing adenosis on the biopsy. That was the finding on the MR. You picked up an additional lesion. The biopsy said sclerosing adenosis. Patients not being planned for any other surgery. Are we always going to go in and wide excise that?
So, sclerosing adenosis is a 2.5 times risk as compared to what you would expect in a general population. So why would you not excise it?
Hold on.
The incidence is really high for sclerosing adenosis. If you look at the denominator of patients who come, it's probably higher than fibroadenomas and cancers put together. Are we
Fortunately, I haven't seen as many.
Hold on.
Okay.
No, Gita, 1 second. Sclerosing adenosis 2.5, but it is 4 times when you look at ADH. You mean to say we're going to wide excise everybody? It's not possible to wide excise. So either you take a call that you're going to be aggressive and you do a prophylactic mastectomy, or surveillance. That is all you're going to do. If you're going to going to put this patient.
No, my issue is not that. My issue is it is possible. It could be upstaged.
So I think the question here is, and I think that's where we're back to the clinical evaluation on it, is if it's a simple small surgery, which is a single lesion, could you just excise it? We potentially plan for an excision or a VAE, whatever it is, versus if it is very florid, diffuse ADH, which has been biopsied, that's not something you're going to push your patient to have a prophylactic mastectomy for without other risk factors. But if you possibly have a single lesion that can be excised when it comes back as a high-risk lesion,
you can. If you operate,
So, you do find sclerosing adenosis on excision of, say, a fibroadenoma, which is,
that for sure.
So then you don't do anything extra for that, you pick it up as part of that excision, but then you don't go back and do anything else.
Correct.
So Mukta's question is sclerosing adenosis a B3 lesion?
And I
So
add to
Mukta,
that question,
as
even
per some
columnar
of the
cell
papers, the answer is yes. Palak.
even columnar cell alteration was suggested as a B3 in some discussion before. Is it?
Yeah.
Okay.
Okay. So any last words of wisdom to all of us from the panelists and any of the surgeons in the group? Basically, vis-a-vis B3 lesions where, so I think what Vaishali says works is clinical radiological correlation helps us. Dipali also says is that ERPR studies for all B3 lesions. Anything else anyone thinks that we should work with? Any take-home advice for us all?
Essentially, I think the B3 lesions are going to be there in your day-to-day practice. Every day you will find somebody with a B3 lesion. But what you do with the B3 lesion has to be clinically correlated. Without the clinical and, of course, radiological correlation, we don't need to jump to any conclusion, or not all B3 lesions need to be like excised. And that's a kind of a take home that I would say. We have already discussed all the pros and cons of which kind of lesion do we address and what to do. I guess that's my last message.
Trupti, there's a question for you in the chat before we end. Is the role of CK56 in sclerosing adenosis?
So there are some lesions which are like a typical sclerosing adenosis, and there are some lesions in which you see sclerosing adenosis colonized by some kind of epithelial hyperplasias. So we say sclerosing adenosis colonized with DCIS or maybe with a foci of ADH. So there comes the significance of CK56. So anywhere in biopsy where we feel some kind of solid proliferation, we do CK56, and positivity, again, the combination of CK56 and ER helps in. So that is where is the role of CK56. So if you see a solid proliferation with loss of CK56, again, there is a probability that the sclerosing adenosis is colonized with some kind of atypical hyperplasia or maybe a DCIS.
Right. Thank you so much, everyone.
Just one last thing, I would like to just say is, you are very fortunate, Shalaka and Nita and Dr. Vani and everybody who have good radiologists and good pathologists. So don't just get carried away by the B3s, because we see a lot of B3s which are not B3s, which are actually, B4s. So, eventually the ball is in your court.
Reviewing everything now.
So yeah, so we have to review, we have to apply our minds. There could be one lesion looking like an absolute fibroadenoma. It's a triple negative cancer sitting there. So take everything with a pinch of salt. Keep your clinical suspicion, index of suspicion high, and just do the right thing. Even if you were to land up doing a core biopsy on a B3 lesion, it's absolutely fine. I always think it is possibly saves our skin, and not just our skin, and does a huge favor to the person sitting across you also by doing that little biopsy, because we don't want to miss it. The whole thing is, after you who? The patient has come to you, and if you were to miss it, where does the patient go? So, I think we have no business to miss it. I would rather err on the side of doing more biopsies than not doing them at all.
Fair enough. And I think that's the take home that I would probably say is that though literature says do less, go de-escalate on these, I don't think in the clinic we have the same kind of radiology pathology across the country to be always able to say it's as simple as that. It has to be a clinical decision, and it has to be patient information also, and a discussion with her. Thank you so much, guys. It's been a fabulous discussion. We hope to be able to do this often enough. We've actually scheduled our next one for the 24th of April, where it's NACT for high-risk T1N0s. Shona is going to be leading this one. We hope to see you all then. We're going to take a break in May and come back in June then. Open to topics that you would like to discuss, dilemmas that you see in the clinic and want discussed. These are always going to be open forum discussions. It's as much interaction as we get, because I think we're all learning from each other. I learned a lot today, and I think that I'm going to be able to take that back into my practice. Thank you so much, everyone.
Thank you.
Thank you.
Thank you so much.
Bye. Good night.
Bye. Good night, everyone.
Bye. Good night.